Good morning, everyone. Thank you for joining us this morning for our Grand Round session at Global Neurosciences Institute. We're honored to host today a distinguished guest, Dr. Desmond Othis. Dr. Othis is currently at the University of Pennsylvania Perelman School of Medicine. He directs the Center of Brain Imaging and Stimulation in the Department of Psychiatry. He is also Associate Director of the Center for Neuromodulation in Depression and Stress, as well as the co-director of the Penn Brain Science, Translation, Innovation, and Modulation Center. He is an associate professor in psychiatry and a staff psychologist seeing patients in the Center for Treatment and Study of Anxiety. He mentors PhD students in the Department of Neuroscience and has secondary appointments in neuroscience, neurosurgery, biomedical engineering, and neurology at Penn. Dr. Othis' research incorporates a variety of methods to understand causal connections in brain circuits and networks for the purpose of optimizing neuromodulation, which he has translated into clinical trials for depression and PTSD. He also works on method development in interleaved concurrent transcranial magnetic stimulation, functional MRI, to advance and refine this growing field. As you can tell from my introduction, he is at the cutting edge of science, which combines both psychiatry, neurosurgery, psychology, essentially anything functional, anything that the brain can do. His research has been funded by institutional, foundational, donor, and NIH grants. It is our honor to host you this morning, and we all look forward to your talk. For the participants, just please remember to put your questions in the Q&A, and we'll address them at the end. Dr. Othis, well, we're all ears.
You. Thanks for inviting me. I would also commend you, Rudy, for pronouncing my name correctly without even getting feedback from me. That's really rare. It's like 1% of people, I think, actually say my name, guess my pronunciation of my name.
Yeah.
That's amazing. Thank you. I want to thank Mike Carsey for making this introduction and facilitating this invitation. Nicole did an amazing job of nudging me over and over until I got the materials in, so I apologize for my tardiness on that. Yeah, and I'm very, very happy to meet you all and talk about my work. The first thing to right off the bat to say is that TMS really works. So there's the latest, greatest version of TMS that's been FDA approved for treatment-resistant depression, has amazing remission rates. So it's like around 80% remission. And that's in a treatment-resistant population, right? These depressed patients have not responded to medication. And this form of TMS is a pretty radical change in a couple of different ways. One of them is that the dosing and scheduling of the sessions is radically different. So the original protocol is daily, Monday through Friday, 4 to 6 weeks, 3,000 stimulations, 10 hertz. This particular protocol is 10 times per day over 5 days. So only in 5 days, right? You're getting already 80% remission in this highly treatment-resistant population. So that's amazing, led to the FDA approval. The other thing to say about it is that this is an fMRI guided TMS target. So the subgenual cingulate cortex has been a focus of deep brain stimulation and TMS for a while. And so this is looking at resting connectivity of the subgenual cingulate, finding a cortical patch that's correlated in time with that, stimulating there with TMS. So that's an important new advance and very consistent with my work. But I'll also say that people have jumped the gun a little bit by saying that this means that image-guided TMS is way superior to other forms. But the head-to-head comparison hadn't really been made yet. But if you just look at the literature as context and say, how well do the patients respond to this form of TMS with this target, it's really amazing, and a lot of people are excited about following it up. All right, so I alluded to this. We have a distressed patient, we bring them in, we apply TMS, and the outcomes, even when they're great, like the Stanford protocol, you're like, okay, that's wonderful. A lot of patients respond. But what about the patients who don't respond? What about the patients who get worse? What about the ones that don't really get any benefit from the TMS? In this case, with these purely clinical outcome-driven symptom kind of assessments, we don't really know what happened in the brain. And I think as neuroscientists, we're pretty frustrated with that. We say, oh, this is sort of like neuroscience brain stimulation because it's fMRI guided in this case. But not knowing what happens in the brain, I think, is really frustrating and limiting and makes it hard to figure out what to do with the patients who don't respond. This is also in the context of some major hits against imaging in psychiatry. So there's been a lot of scrutiny lately over, hey, why aren't we using imaging in psychiatry for anything, right? Why does it not inform any clinical decisions? We've been doing it for many decades, spent a lot of money, and the psychiatrist clinician has no use of imaging to make their decisions on treatment. Right, so that's frustrating, and all the increased focus on making imaging work better. There's a lot of clever ideas for doing that, but with the background that even some of the really large imaging studies, now we've done so many studies in so many labs around the world that you can start to combine and get really big sample sizes where you should be able to detect really small effects. But many of these are coming out saying there is nothing consistent. Right? If you look at a patient population like depression, and you look at all these different imaging measures, the biomarker is really elusive. One of the difficulties is that you make these beautiful images for your publications, and we don't know how that translates into the individual patient data that we might collect. So you can have something like an average brain, which is a reasonable representation of the study that you did, but it might not actually fit if you take that and try to apply it into an individual patient. You don't really get a map of that person's brain from the average. And we've known about this in basic cognitive neuroscience studies for a long time. The images on the left are ones that you get from an average from a really basic cognitive task that includes working memory. It's a 2-back versus 0-back. So the contrast of the harder part of the working memory compared to an easier trial. So you see all these brain areas light up on average on the left. You say, okay, yeah, that looks pretty consistent with what we think in the literature, what brain areas should light up. But then you look at your data a little bit differently here on the right, which is they're saying how many participants actually showed strong activation in these regions. So you threshold it based on that, like how many actual people had strong activations at that little point, that voxel in the brain. And then the map looks like, so there's some overlap. You say, yeah, there's some overlap as well. There should be, but it also shifts the activation around a little bit. A bunch of things disappear. So I would argue that the map on the right is probably more relevant to the individual patient. We're getting closer as compared to the average brain on the left. I always want to. I collaborate with some DBS people, but that's not my main research interest. But I just want to make you aware that other modalities, other brain stimulation modalities, also are really trying to focus on what's the best image-guided target for treating patients. And so in depression, treatment-resistant depression, there's some nice evidence that you find convergence between several white matter pathways, and the patients respond much better. And people have tested individual pathways and had some decent results. But that's kind of latest iteration that you find this convergence of several major white matter pathways. And when you do that, the patients seem to respond really particularly well. And there's some that you can't get at an atlas, like the medial forebrain bundle. So you can't even find it unless you use the individual imaging to guide where you place the electrodes. So that's kind of well entrenched, should mention as well. Yeah, so in terms of figuring out that individual patient variability and what actually happens in the brain in response to TMS, we do something that's fairly unusual still, which is to put the TMS on the participant and put them in the MRI while we're applying TMS to see what actually happens, what circuits are engaged, and what networks are engaged, and which ones of those are relevant to outcomes that we care about clinically. So there's this kind of nice trick that we can capitalize on, which generally is seen as a shortcoming of fMRI, which is that the signal change in the brain happens fairly slowly relative to a cognitive or a stimulation event. So if you just show something like flashing checkerboards on the screen and you want to see the visual areas of the brain light up, if you want to capture a really nice signal like that for visual cortex, it takes seconds. It takes multiple seconds before you get a really strong signal out of the brain. So it's really convenient for us to apply a TMS pulse, turn off the pulse, turn on the image acquisition, and capture what happens in the brain. If you didn't do it that way, if you just hit the TMS pulse at the same time that you're trying to read out the brain activity, you'll corrupt the signal. So the TMS pulse is very effective at doing that. But given that the bold blood oxygen level dependent response in the brain is fairly slow and sluggish relative to something that happens in the brain, we can ping a circuit and capture the downstream effect in the brain without corrupting the signal. So what happens when we do that? Our first kind of foray to this was looking at some of the canonical resting state networks to say, okay, people believe there's something like a default mode network, salience network, et cetera. So can we actually engage networks if you stimulate with the TMS coil? Generally, a TMS coil, right, you apply it to one place and you stimulate. And there's some assumptions that downstream things are really important, but just figuring out whether it's possible to engage distributed networks in the brain from applying TMS to one of those nodes, so one of its partners that's accessible to TMS, that was kind of unknown. We kind of assumed that that's possible. But we were some of the first people to demonstrate, yeah, you find a part of a network, you engage it with TMS, and the rest of the network actually comes online. It engages the network. And also testing more causal theories of how the networks interact by, instead of just looking at their resting time courses and the correlations over time, we can actually engage and manipulate the networks so that we can show which ones are correlated positively, which ones are antagonistic. So it gives us this really nice tool to show how the downstream networks are affected when we apply TMS. So since joining the faculty at Penn, my focus has been on some of these deep subcortical networks and structures that we think are particularly relevant to anxiety and depression. Think, okay, well, TMS cannot reach the amygdala, right? It's superficial. It can only engage the cortex. So how could it be possibly useful to engage some of these deep brain areas that we care about? Well, we've taken the approach that the resting connectivity, so the correlation in time between the deeper brain areas and these superficial areas that are accessible to TMS, we think that might be a good pathway, that might give us a good target for engaging the deeper brain areas that we care about. So we need to test that, make sure that it's actually possible. The design that we use is, if you're familiar with event-related fMRI, we do something exactly the same, but instead of having a flashing checkerboard or a picture of a face or something like that that you repeat many times, instead we send a single TMS pulse through that cortical spot, and we capture what happens downstream in the brain when we average all those trials together. So this is not neuromodulation, right? We're not doing repetitive TMS. We're doing single pulses and trying to capture what gets engaged downstream before we do any kind of neuromodulation that we think will change communication in the circuit. So this is more like a ping to see, okay, when you engage this brain area, what are the other downstream brain areas that come online? And so we get a whole brain map like this. So you can say this looks like any fMRI study that you've seen. They make maps like this, but ours is actually really different in a fundamental way, which is that we engage the circuit with this pulse of TMS. So it's much more of a causal map of what happens in the brain when this area of the brain is active, instead of just seeing correlations over time, which is what we're generally doing in an fMRI study. The advantage is that you really understand a lot more about what happens when this particular brain region is active and what its downstream partners are doing in response to activity at that spot. And so the way we do our brain stimulation is having a neuronavigation system. So you can collect imaging data of any type that you think is really relevant to the stimulation target that you want to hit. So you can use structural MRIs, you can use DTI, you can use fMRI from resting state like we do, or a task, a lot of options. And then you can kind of map up the skin surface, match it with the imaging data in front of a camera, and you can stimulate anything, any brain region that you want to. So that all can be done offline outside of the MRI using that patient's individual data. And you also have the advantage of the feedback from the camera to make sure that the participant and the TMS coil are held in place and make sure that you stay on your target as you're delivering thousands of stimulations. So that's an advantage. So one of our first targets, so just like the Stanford protocol and much of the deep brain stimulation work for depression, we're focusing on this deep region of the subgenual anterior cingulate cortex, which is that little red patch in the bottom image. And we're looking at functional connectivity targets on the surface of the brain that we think might be pathways down to the subgenual cingulate. And we ping those pathways with the TMS fMRI to try to demonstrate that, yes, in fact, we can reach these downstream targets indirectly with TMS. So we set out doing that, and we found some evidence that we can do that. And the direction was a negative bold response. So you see this decrease in the bold response in the subgenual cingulate. And we can hit a control region like motor cortex and show that this pathway works better at engaging the circuit that we're interested in. So we've replicated that first initial study. We also looked to test out what functional connectivity target may work the best. So you can look at targets on the cortical surface that are anti-correlated. So when the subgenual is up, it goes down. Or you can look at regions that are positively correlated in time, just they follow each other. One goes up, the other one goes up. And most people in the literature, including that Stanford protocol, are focused on the anti-correlated spots with the assumption that you stimulate these anti-correlated spots and you'll decrease activity in the subgenual cingulate. But that needs to be proven. These are indirect connections. There's a lot of intermediate kind of pathways that may contribute to the eventual downstream effect in the subgenual. So we do these pings to the circuit, and we found in a larger cohort of healthy people, 70 healthy controls, and in this replication study, we found that connectivity works for the subgenual. You can get an evoked response in the subgenual. And in the healthy people, it doesn't seem to matter. If you take a strong connectivity target, whether it's positively correlated or negatively correlated, you get a pretty nice engagement of the subgenual cingulate. In the depressed patients, however, we found something a little bit different, which is that the anti-correlated spot that everybody's chasing clinically, including the Stanford protocol, it engages the subgenual cingulate in depressed patients. So that's the little blue box plot on the left. It's not zero, right? It does engage the subgenual, but in our data, in our patients, the positive connectivity spots worked a lot better at engaging the circuit. So if we assume that TMS from the cortex reaching the subgenual is mechanistically critical or even important in contributing to the clinical outcome, that's our target, then people may not be chasing the most ideal target in these anti-correlated zones. We should try the positively correlated spots and see if those also affect symptoms, and maybe they'll do even better. Also want to mention that we have other pathways that we're testing out. So this is an amygdala pathway that we do the same thing. We use resting connectivity to guide where we think we might want to stimulate to engage the amygdala. And we found some evidence that we can do that in a small, healthy cohort that we then look to replicate. And we also included some DTI measurements because there's some evidence from DTI in human imaging and also in non-human primates that there may be a direct pathway between this ventrolateral prefrontal zone and the amygdala. So we wanted to test for that possibility. So we did some tractography between our stimulation site and the amygdala, and we found that we could engage the amygdala. So that's a nice replication, but also that the fiber density of this putative pathway between our stimulation site and the downstream amygdala, the individual fiber density was correlated with the strength of the amygdala evoked response, suggesting that TMS may propagate through that pathway in order to engage the amygdala. Say, okay, these are nice little tricks, but what we really want is some clinical evidence. Is the stuff you're doing with these single pulses, is that even relevant for the kind of repetitive trains that people are doing in a treatment context? And so we set out to demonstrate that by doing this brief intervention to see if we can move symptoms and if we can relate the TMS fMRI circuit pings to a clinical response in depressed patients. So we did this brief intervention over 3 days with this form of TMS called intermittent data burst. And we found that when you engage the circuit before the intervention, the strength of that subgenual evoked response was correlated with depression improvement. And we think that means that the pathway, the circuit integrity between the stimulation site at the cortex and the subgenual cingulate is effectively measured by our TMS fMRI paradigm, and that tells you something meaningful clinically about how that individual patient will respond. So that hasn't been demonstrated before. I think it's a really important connector piece between the imaging data and a clinical response. And we also did the pings again after the intervention. Said, okay, can we use TMS fMRI to show a change in the communication of that pathway? Can we show some evidence of neuromodulation by using these circuit pings with TMS fMRI? And we found that there was a change. There was a significant change pre to post intervention, which is good. And we also showed that that change was correlated with symptom improvement, suggesting that this ping of this circuit is supporting a mechanistic explanation for how TMS actually affects the patient in the context of an intervention when we're improving their symptoms. And it also broadly supports and validates that subgenual cingulate as a reasonable target to chase in continuing to work on brain stimulation for depression. We also have some control conditions. We stimulated a couple of different pathways, and what we found was only the pathway that we stimulated for the intervention, the subgenual evoked response to only that pathway was related to the depression effect. So if you stimulated somewhere else and you get a little signal in the subgenual, it didn't predict a depression improvement. If you looked at other brain areas, that may be relevant, like the amygdala, in response to the that cortical stimulation spot. You also didn't show an association with depression improvement. It was really specific to that pathway that we were aiming for in terms of explaining the depression improvement. I will say that anxiety also improved. So there's a symptom scale called the DAS-21 that there's a depression subscale that has a lot to do with kind of depressed mood, as you would assume, and the anxiety subscale has a lot to do with an arousal type, anxious arousal type anxiety symptoms. So we saw improvement in both, but only the subgenual evoked response change was associated with depression improvement, not with anxiety improvement. So that suggests that this pathway is especially meaningful for depression. And you say, well, if the subgenual wasn't responsible for the anxiety improvement, what was? So I'll get to that in a moment. But I also want to mention that most of the published studies are on treatment-resistant depression because we're kind of looking for alternative treatments for them, given that they don't respond to medication. But that doesn't mean that your typical depressed patient who's non-treatment resistant wouldn't also benefit from TMS through the circuit. So we just split up our data according to whether they were treatment resistant in blue, which, as you might guess, their symptoms were even more pronounced. And they responded really well to the TMS, but also the more typical patient who's not so treatment resistant, even with lower initial symptoms, they also benefited significantly from TMS. So we should broaden the scope, include more patients in our studies, include more patients in the FDA protocol. Hopefully more patients get benefit out of it. So back to the question of, well, we know why all this focus on the subgenual cingulate. We know there are networks involved. Like depression is not one brain area. Like why are you only focusing on that brain area? And it's sort of necessary in this case because we put the TMS coil on one spot. So we're looking for a specific network, and connectivity to one target simplifies things a lot. But as I mentioned before, we get a whole brain map, right? Every time we do these pings to the circuit. So we could look in other brain areas, and there may be other alternative targets that pop out and that are interesting to us. So we have the depression improvement measures, we have the brain evoked response measures, and we link those together and cast a wider net, look at the rest of the spots in the brain. And if you look on the left set of images, it turns out the subgenual cingulate, even when you look wider across the brain, turns out to be one of the hotspots that are really associated with depression improvement. That's a reasonable, viable target. It's one of the most important brain targets, but it's not the only one. There are a variety of other brain areas, like part of the hippocampus and posterior cingulate, that are also showing a change associated with depression improvement. So we're not trying to argue the subgenual is the only place that you should care about. And in fact, some of these other brain targets are accessible to TMS directly. So if you're looking for a different target other than the subgenual, you can form hypotheses based on these imaging data. And then also, of course, with the anxiety improvement, where we also have this opportunity to look in the rest of the brain. So we can see a nearby region of ventromedial prefrontal cortex, for example, that engagement and change of that circuit is associated with anxiety improvement, just not the subgenual cingulate. So that gives us, again, a new viable targets that we can attempt for treating anxiety. So I want to mention that we're not the only ones thinking of using these concurrent imaging and brain stimulation techniques to try to figure out what happens at the individual patient level, how to optimize things, how to figure out how brain stimulation actually works. So this is a group in Toronto who turned on deep brain stimulation of the subgenual cingulate and looked at what are the connected regions that the fMRI shows up when you do that, and how is that related to clinical response. So in these patients, when you turn on the subgenual cingulate DBS and you capture the fMRI response to that, they showed an association that this dorsal cingulate cortex, when that's engaged, then the patients have responded really well to deep brain stimulation to the subgenual cingulate. And so there are a couple of groups that are doing things like this. Moses Lee at UCSF is doing this with OCD patients and finding some really interesting things. There's a new electrode that is even 3 Tesla compatible. And I think having more people doing better quality imaging with paradigms like that as they're kind of shown to be safe is going to teach us a lot about the circuit engagement, maybe even optimal electrode placement, and especially what networks change and how to further improve our brain stimulation techniques. So it's not just the image guidance that says, let's find this pathway, let's choose this target, but also showing at the individual patient level how the brain stimulation actually works and how it's contributing to symptom improvement. I think that we could really refine and personalize the targeting in a variety of brain stimulation modalities and indications, doing these kinds of things. Okay, so I did a brief intervention, showed some symptom change, and did TMS fMRI, but I'm also kind of arguing for this different connectivity pathway, different connectivity target that other labs and clinics are not yet pursuing. And so we need more clinical data to support that this is a reasonable, viable target. And so we did a clinical trial in a mixed group of post-traumatic stress disorder and major depressive disorder, focusing on this target and looking for the positive connectivity cortical sites that we've shown, right, with the TMS fMRI. This engages the circuit pretty well. It does it in patients in healthy controls. So let's do a more full clinical trial and see if it improves symptoms. So this is our individual targeting. Right, we were always able to find a nice target in dorsolateral prefrontal cortex in every patient. So we found a nice target there, and we compared this to a scalp-based target. Now that's the original way that TMS is applied, right? It's not very individualized. You measure things on the scalp and you make some big assumptions about where in the brain that you're stimulating. And so since, like, even with the Stanford protocol, there hasn't been a head-to-head comparison with fMRI guided versus not. And we really wanted to do that. So we're thinking, we think our target works really well, and we want to measure it relative to a scalp target. Now, this is one of the iterations of scalp target. There's a couple out there. There's one based on the F3 electrode site that is really popular. This one is 6 centimeters anterior to motor cortex. So you find a motor evoked response, you go 6 centimeters anterior to that, and you assume you're kind of DLPFC territory. Which you may recognize is a major shortcoming of the scalp-based targets. You're like, well, people's brains are fairly different and people's head sizes are pretty different. There's a lot of variability there. But that's what they use in the clinic, because that's really easy to do. You don't need any special equipment. You don't need any neuronavigation system. You just like do a few scalp-based measurements. You say, we're close enough. Let's throw the TMS coil on here and stimulate. And it's sort of amazing that it's not already in the literature that image guidance beats a scalp-based target. There have been a couple of attempts that are published where they haven't found a clear difference. But I think a lot of us assume that it's because they need to refine their image-guided targets. And so, especially in light of that Stanford protocol, saying, wow, these patients are really responding well to the image-guided. How important is the image-guided actually? So that was a major goal of this clinical trial that we did. We also had them do a task, which I won't really talk about, but if there's some of you out there that are really like gung-ho about brain context and brain stimulation interactions, we have some like support for the idea that the brain state that you're in and the task you're doing when brain stimulation is applied may affect some of your clinical outcomes. So I'd be happy to talk more about that offline if anybody's particularly interested in that. But let's just focus on the fMRI guided versus 6 centimeter scalp target. And I say, okay, well, maybe you're in like radically different regions of the brain, and that's why your fMRI guided is different from your scalp-based target. But if you look in template space, like you stretch everybody's brain to fit into one template, and then you look at where their targets were, there's a lot of overlap actually. So the 6 centimeter are the blue spheres, and the fMRI guided are the red. There's more variability in the red, right, as you might expect, but they're highly overlapping. And so this is decreasing our chances that we're going to find something different between scalp and fMRI because they're broadly in the same category, in the same regions of the brain. And so if we do find evidence that image guided works, this is a big deal. This is like a sort of small tweak to where you place the TMS coil. Does that really make any kind of clinical difference? So on the top left, this is the PTSD checklist. So PTSD symptoms, you can see the change over time. Improvement is in the negative direction. So fMRI guided is the purple and scalp-based is the gray. And you can see over time across these 2 weeks of treatment that they received to each target, they're kind of neck and neck. And at the end, post-treatment, they both improve decently, right, for PTSD symptoms broadly across the whole scale. Now, on the top right, this is our depression scale, and you can see that pretty quickly after 4 weeks, you can see that they start to separate. That the fMRI guided starts to beat the scalp target, and it becomes even more pronounced post-treatment in the follow-up period. So the fMRI guided is clearly improving symptoms of depression more than the scalp-based target. And there's a difference of like 60-ish% versus like 50% improvement. So you say, well, how big of a deal is that? But I think that in this population and looking at all the kind of outcomes in terms of what they will cost the health system, what they'll be able to functionally do, 10% difference may actually make it worth it to do image guided, and maybe in some subgroup of the patient population. So we wrote a grant recently saying that, hey, let's treat people with a scalp-based target, right, for a couple of weeks. Maybe there's going to be a lot of responders to that, but what if they don't respond? Let's really focus on the people that aren't going to respond to the scalp-based target, and in that case, we're arguing the expense of getting the image-guided targeting may be worthwhile clinically for those patients. So I think it's sort of like this use case scenario: who should get the image-guided targeting, and we're trying to nail that down. But statistically, it's better. And so if you have the resources, if you have access, the image guidance is going to give you a better target for improving depression. So now off my soapbox, I also looked at some of the PTSD symptom subclusters. So there are different kind of clusters of symptoms that hang together in PTSD. And one of them that you can pull out of this broad scale is the hyperarousal. So really being on edge, easily triggered by things, easily startled. So those kind of symptoms. Patients improve better with the fMRI guided target again compared to the scalp-based target. All right, so a vision for the future. We're thinking that if we start to build this evidence that image-guided brain stimulation works, and that we know what the downstream brain targets are or the networks that we really want to engage and modulate, like we're building up this evidence, this database. And it could even be symptom specific. It can be even like patient diagnosis specific, but we're building up this evidence based on the brain stimulation in the scanner and capturing the brain response to TMS. If we're figuring this out, we may, envision a case where we say we have this individual patient and we have multiple targets that we think may engage the network, may engage the circuit that we care about. Why don't we hit several of them in our scan session? And whichever one engages the network the best for that patient, let's optimize, let's further optimize based on the TMS fMRI data, that pathway for that patient, and hope to even further improve the outcomes beyond just the image guidance as a baseline measure to decide where to drop your TMS score. So our data support this. I think it would be really fun to try that out. So in conclusion, I think we've demonstrated now with some small healthy cohorts, then replicating in bigger cohorts, that we can do this. The fMRI guidance works to engage these intended targets, at least these initial ones that we focused on so far, subgenual cingulate and amygdala. We also showed that target engagement, as demonstrated with the concurrent TMS fMRI, actually tells you something clinically useful. Right? It tells you something about the circuit integrity and how the patients will respond clinically. And we are also showing in our first clinical trial and comparing the image guided to the scalp-based target that at least on depression and some of the subscale of PTSD, we can do a better job of treating the patients if we use the fMRI guided targets. And then we also gathered some of those whole brain maps where we can guide new hypotheses for new targets and try multiple pathways and see if we can treat, for example, anxiety more specifically through a different brain stimulation target. In my center, we have some projects that all of them are brain stimulation related because that's what we do, and all of them include brain imaging. We're trying to use some closed loop approaches for improving working memory. We have some other ones that are personalizing the maps of patients doing worry and depressive rumination to try to focus on those symptoms more specifically. We don't think we found the best image guidance yet, and so we're open to acquiring other informed stimulation targets. So resting fMRI, task fMRI, DTI, and also there's some different ways of parsing networks in the brain and deciding that, okay, this is like a particularly important node in the network that should drive the downstream parts of the network even better. And so we're testing those out. And then also working with Casey Halpern, a neurosurgeon at Penn, on this really clever OCD treatment project, personalizing based on stereo EEG. So we do this really awesome symptom provocation and these tasks and collect the signals while the patient's doing that in our inpatient stay and trying to personalize the placement of the targeting, and that's going really well. And I'm also trying to test out just even more basic things about how TMS works by going into the epilepsy monitoring unit and doing some TMS while the patients have their stereo EEG implants in place. So the funding has been really good. This is really consistent with some of the NIH recent funding announcements where they want in a treatment context to show engagement of a target before you really set out on the bigger clinical trial. And that's a really good fit for TMS fMRI to say that, yeah, we can engage that circuit really effectively, and then we should use that evidence to build novel clinical trial targeting for the patients. So that's going really well. I also have some really amazing collaborators that I couldn't do the work without. And yeah, our center is new. We don't have a physical space yet. It's under renovation. But if you guys would like to stop by and visit us sometime, we would love to have you and show you around. If you're interested in other applications of brain stimulation and imaging, I host a speaker series virtually on Wednesdays at 1:30 that you're welcome to attend. Shoot me an email. There's another speaker series. Like today, there's a guy from Boston who does alternating current stimulation for memory improvement in older adults. And so if you want to link to that, I can send that to you. I think we're doing a lot of really fun collaborative brain stimulation things at Penn. So if you want to be more involved, yeah, shoot me an email. I'd love to talk to you. And I'll stop there.
All right. Well, thank you for this thought-provoking and engaging talk. We've had a few questions. Actually, some you've already answered through the talk, but one is any thoughts on using an accelerated protocol like SAINT to stimulate M1 for neuropathic pain states?
I think there's no reason not to. So I don't know if M1 is ultimately the best target for treating chronic pain, but there's a good evidence base that it works. And so why not try it? I think people have been scared to approach that high of a dose for safety reasons, but the latest safety guidelines suggest that we should open up the floodgates. We should be a lot less afraid of like medications that lower the seizure threshold. The actual incidence of seizure is so low that the clinical benefit far outweighs the risk, and that we should be doing a lot more of it.
Perfect, thank you. In terms of talking about PTSD and depression for clinical indications for people who what obviously you've shown that whether it's resistant versus not resistant, there is benefit. So do you typically you guide your patients whether they're resistant or not, or do you only see the resistance when they get to your door, they're already resistant to other treatments?
Yeah, that's a good point. So we don't categorically exclude patients based on whether they're treatment resistant, but the patients who are out in the community looking for some alternative treatment are often treatment resistant. So we have a pretty high proportion of them that qualify as treatment resistant because they're typically like desperate for something else to help them. But I think that as the like public at large becomes more familiar with TMS, and there's less kind of association with things like ECT and the cognitive side effects of that, and people recognize that this is more precise, that there are no cognitive downsides of TMS, as that's kind of put out into the public knowledge, then we should expect more patients to sign on.
Yeah, I agree, and I think one of the main things that you brought on today is instead of asking why, the question is why not? Because as you said, it's very safe. And then as we're exploring more about obesity, OCD, all the behavioral things that we know, because the group in Toronto, as you know, tried DBS for obesity, and then the problem is that the patients end up turning off their DBS because they wanted to eat. So that goes back to the basis of behavior in patients versus whether TMS can help with that. So the question then for the TMS, do you do multiple sessions, or once they're not candidate for it down the road, let's say they respond well, but down the road, do you see relapse in terms of, or is it something that that they're gonna have to have continuously throughout their life undergo?
Yeah, the patients who respond well to the initial TMS treatment, um, their symptoms tend to slip, and they tend to start kind of over months following that. They tend to start getting a bit worse. But the good news is that if those patients come back for like a booster of TMS, they respond really, really well. And so it's my bias as a clinical psychologist that the brain stimulation on its own isn't going to change enough of the person's life and their functional impairment and their habits and so forth, that they need to be supported in other ways, for example, through psychotherapy. So I see in the broader clinical context, I see it as like these patients are so ill that they have a hard time responding to other forms of therapy. But if you can kind of nudge the circuits in a healthier direction, and then like expand on that learning and the life changes with some coaching from a therapist, that the treatment gains would even further increase. But it definitely, just in terms of the brain stimulation, there's solid evidence that the patients who come back for booster sessions really respond well to that.
Right. There is some interest shown in the live series that you mentioned, and they're asking your email address. Maybe I don't know how we can get your email address to some of the participants. Um, Maybe if you we can share your email with us, so we just don't put it out unless you're okay putting it out there. But you know we can
I'll
have
put
it.
it in the chat. So I think anybody who's signed on is totally welcome.
Perfect. All right. All right. Do we have that then? Well, again, thank you. This has been a very interesting topic, and like I said, this is the cutting edge of neuroscience with a with a big title, including neuropsych, neurology, neurosurgery. It's all included. So we were very lucky to have you this morning. This has been an exciting, and we look forward to continuing the conversation to have maybe some collaborations and to watch what you do in the future. We're all excited.
Thank you so
Thank
much. I really enjoyed it.
you.
Yeah, take care, guys.